Okay. Hello, everyone, and welcome to today's ADRA Health Technical Learning Lab webinar. We are so excited that you've joined us this morning. The HTLL hosts these periodic sessions to strengthen our collective capacity and to create a space for learning across our global ADRA network. Today's conversation focuses on an issue that continues to emerge as a priority across both humanitarian and development settings: mental health and psychosocial support. As many of you know, ADRA teams are working in vastly different contexts around the world, but we share a common goal: making mental health care accessible, relevant, and responsive to the communities we serve. This session highlights two distinct yet complementary approaches that embody that commitment. First, we're going to hear from ADRA Norway, which will walk us through its Mental Health Champions program in the Sahel. Our first presenter for that will be Monette Indal, Program Advisor and Mental Health and Psychosocial Support Specialist at ADRA Norway. Monette brings more than 20 years of experience in psychiatric healthcare and is one of the few specialists in psychomotor therapy and complex trauma. She's deeply passionate about helping people understand themselves and access their own resilience. And then we'll shift to ADRA Myanmar, which will share its experience delivering integrated mental health care and clinical services through mobile medical clinics in conflict-affected, hard-to-reach areas. Our presenter for this will be Dr. Nisar Ulkak, Health and Nutrition Coordinator at ADRA Myanmar. Dr. Nisar has led major health programs in South Sudan, Yemen, and Liberia, with a growing focus on integrating mental health into primary care systems. His work continues to strengthen health systems and holistic well-being in crisis-affected communities. Hopefully, by the end of this session, you'll have a clearer understanding of how community-based mental health initiatives and integrated clinical services can work together to strengthen mental health and psychosocial support across diverse contexts. You'll also be able to identify opportunities to collaborate, adapt, or replicate approaches that best fit the needs of your own programs and communities. Just before we begin, a few housekeeping notes. Please make sure you remain muted throughout the presentations to help us maintain a clear audio experience. If you have any questions, feel free to add them to the chat. We'll have a dedicated time for questions before we close the session. Lastly, this session is being recorded. If you prefer not to appear in a recorded space, you're welcome to log off now and watch the recording later on the HTLL YouTube channel. I'll drop a link in the chat for you later to that YouTube channel. And also, if you would like subtitles in a language of your choice, you can turn them on using the Zoom caption feature. Just click the CC button on your toolbar to enable translation and then select the caption option or language of your choice. If you don't see the CC option, click the More button, which is the three little dots, and thereafter click Captions and then Translate. And again, choose the language of your choice. With that, we're going to get started, and I'll turn it over to our first presenter, Monette. Over to you.
Thank you for the introduction. I'm so happy to be here with you. I want to tell you a little bit about the program that we have, how we integrate mental health into programs. ADRA Norway has mainly education programs. So we support schools, and the Aspire program, which we have the mental health champions in, are situated in these 7 countries: Ethiopia, Mali, Myanmar, Niger, Somalia, South Sudan, and Uganda. Next picture. You can flip to the next, there you go. So in these countries, there are limited formal mental health infrastructure. and also very little resources. I can tell you a little bit about Niger was the first country that I worked in, and also the first where I trained mental health champions as well as health workers. They're a population of 25 million people, and I was told there's only 3 psychiatrists. I talked to the health ministries. There's no registered psychologists. The ones working there works with other NGOs. So you can just think that there's limits of formal help, especially in the mental health care. But the need is great. WHO states that 90% of the population live under so harsh conditions or has experienced so tough things that they are in danger of that affecting their daily life. It doesn't mean that all of them do that, because people are resilient despite their life challenges. And I want to talk a little bit about why do we do mental health champions and how can that help at all? It's mainly because people need each other. And by being support for each other, that is a great resource to both help and also resilience. Awareness of mental health and knowledge about it is also a way to live with what we have experienced and to manage the challenges. Next slide. So what does the training contain? Because there's no way that I can share 8 years of education with champions in just a 1-week seminar. So I decided, together with other professionals, that these were the most important. The training contains psychological first aid, which basically is look, be aware, see if somebody needs help, listen as one of the key things. I'm very big on that. It's very important. And link the person to either their community or other instances that can help if needed. Feelings are not dangerous. It's what you do about it that can cause danger. When people are angry, they can do things that are not good, for example. But knowing feelings, understanding your own feelings, and that there are multiple feelings, is important to understand yourself and manage when things are bad. For example, if you're angry might be because you're scared, and so forth. What is important in resilience? And we go through the basic needs. Sleep, food, water, exercise, as well as being together, the companionship, belonging, and laugh, arts, and music are all parts of being resilient. Some main knowledge of the main mental health problems like depression, anxiety, and trauma, which is a huge thing in the countries that we work in, as well as other main illnesses. But this is not a way to know how to diagnose. It's maybe mostly to understand and to get more understanding of these illnesses and what it is, and thus also get compassion for the person that is not ill-willed. It's not their bad mood or they're not wanting to. It's an illness. Mental health is just like another illness, and it might be of what happened to you, not because who you are, so to speak. And what I want to mention, especially when it comes to trauma, is that I want you to know that, for example, flashbacks, which is often talked about, is an experience. People experience it how it is now. When they experience a flashback, it's about they experience things as if it happens again in the moment. So the key here, why we should listen, why we should use arts, why we should write, is basically to help that trauma become in the history part of the brain and not continue to give us flashbacks and continue to give us the sense of the anxiety as if it's happening in the moment, so to speak. Then there's simple tools to manage mental challenges. And this is where I found my knowledge very useful, because as a physical therapist specialist, we use the body as a resource. We're not so counted on medication or communication therapy. We use the body, and everybody has a body, everybody can use it. So here I can give you a little tip. Counting and rhythm, it's a very great tool for managing challenges, managing anxiety. Thus also the things that you have in your culture about singing, about rhythm, and so forth can be very useful to also for your mental health. And we also discuss in this program ideas how to integrate mental health and psychosocial support in other programs activities. And I'll give you a little hint on how that works. Next slide. Because there is limited funding in mental health. It's not a very popular thing to fund, unfortunately. It's a lot easier to get funding for other more countable things like vaccines or food supply and so forth. So with the funding even decreasing more this year than it has been, we've discussed how can we integrate the mental health focus in everything that we do. So by knowing that sport activities, cultural activities, play, music, gardening, cooking, all of these also help the resilience by being together, doing something positive, focusing on what is good, what we can control, and also maybe noticing those that maybe have challenges, asking them a few questions, listening. The belonging is great in these activities, gives hope, and hope is what gives us strength to continue despite the challenges, even though they're not resolved. Next slide. It is vulnerable to be a mental health champion. It is vulnerable to be a specialist in this field because you hear a lot of things and you feel you so much want to help people, but you can't really fix or help everything. But having a peer-to-peer support, talking to others in mental health champions, talking to other professionals is important to sort of find common ground also for us. We found in our programs that teacher circles are a great way where the teachers not only share their pedagogical challenges and learn from each other, but also discuss challenges, problems, and so forth. And this creates resilience despite the challenges. Support from donor office. I support my mental health champions, our mental health champions in the programs with meetings, with cheerfulness, with knowledge, to have physical kind of coffee breaks where it's not such a structured program, it's not recorded, but we discuss and just talk. And when we have other workshops where we meet physically, to have meetings in the evening where people are welcome to come if they want to, and we can discuss. And self-care. Of course, it's important for me too. Even though I have lots of knowledge, lots of experience, I'm not immune to mental health challenges. So for me too, it's important to sleep, eat, drink water, exercise, being with the ones I love, and share and enjoy the positive moments. Next slide. So lastly, what is most important? I often get this question. What do I need to know? How can I start? Because people are so afraid of doing something wrong. Maybe they can make things worse. Yes, it's possible to make things worse, but by not doing anything, you probably make it even worse than that. Then at least you get it worse. So listen. That's my key advice. Listen and listen more. Because for the other person, you can't fix everything, but for the other person to talk about their problems, they might find the solution themselves. And if not, their trauma, their bad experience will be placed in the history function of the brain and will not continue to haunt them as if it's in the moment by them telling what they've experienced. But don't ask too much. That's why I said listen more. Be there to listen. And then remember, feelings are not dangerous, but they can be uncomfortable. This is important. Feelings are not dangerous, but they can be uncomfortable. And I had in brackets, because it's what you do about it that can be dangerous. The feelings in themselves is not dangerous. And people often lack a language for their experiences, especially children, but also grown-ups. So use the arts, theater, painting, writing, music, anything that can help you both act out the trauma, act out the bad history, but also create resilience for the future. That's it. Thank you very much. Over to Nizar.
Thank you very much. Thank you for joining today's webinar. I'm pleased to present on how mobile medical clinics are delivering the life-saving primary healthcare services while integrating the mental health and psychosocial support in some of the most challenging humanitarian contexts. I will talk about ADRA operational approaches and field experience and the impact of combining medical care with the essential mental health and psychosocial support to strengthen the resilience and well-being of crisis-affected communities. Next slide, please. Health system collapse during crisis, disrupting the public health services delivery and the surveillance system. In the context of conflicted affected area and in the humanitarian context, mental health and the psychosocial support needs are rising due to the exposure to violence, loss, and chronic stress. Next slide, please. Why mobile clinics? Mobile clinics are a rapid, flexible health delivery modality in emergencies and hard-to-reach areas. Mobile clinic ensures continuity of life-saving primary healthcare services, maternal, neonatal, child health, and essential medicine supplies where facilities are not functional. Integration of mental health and psychosocial support into mobile clinic services strengthens holistic care and supports recovery and resilience. Next slide, please. Mobile clinic operations, the structure of the mobile clinics, it have flexible modality with multidisciplinary teams, including medical officers, nurses, midwives, psychosocial counselors, community health workers, and volunteers. And considering the remoteness and availability of the human resources in the hard-to-reach areas, sometimes would give flexibility to replace medical doctors with medical assistants to fulfill the gap and provide the services. Next slide, please. Mobile clinics are deployed in the target areas, and it have rotation on fixed schedules to underserved or displaced locations, guided by the health cluster coordination mechanism and coordination with the local health authorities or implementing partners to ensure that the services are provided on a regular basis to the targeted communities. Next slide, please. Mobile clinic service package, it includes the comprehensive primary healthcare services, including the IMCI, RMNCH, SRH, NCDs, CDs, nutrition screening, EPI support, and MHPSS. So this is a comprehensive package to ensure that all the beneficiaries are receiving the life-saving health services through the mobile clinic activities at the community level. Next slide, please. How do we integrate mental health and psychosocial support into the mobile clinics primary health services? So the challenge, very few health providers in the rural or conflict setting have training or experience in mental health care. How do the mobile clinics approach these challenges? So in our experience, we have two different approaches, community health and nutrition volunteers or community health workers. So initially we provided the training, a proper capacity building plan for the volunteers and the community health workers, and psychological first aid and basic case identification. To provide a calm, supportive first contact for people who appear distressed, connect individuals to the mobile clinic team or other available services for further assessment and care. This is the first component where we engage the community health volunteers and the community health workers so that they can mobilize the resources at the community level to engage with the mobile clinics or any other health facilities. Next slide, please. As a second part, the challenge is quite similar. Very few health providers in the rural or conflict setting have training or experience in mental health care. And how do the mobile clinics approach this challenge? So health staff, including doctors, medical assistants, nurses, midwives. So training on they are trained on WHO mental health gap action program so that they can provide the basic counseling, identification of the mental disorders, and support the beneficiaries with the basic counseling. And in case of critical mental health disorder, they can do the referrals. Next slide, please. Okay. Mental health gap action program. This is a practical set of WHO guideline to support non-mental health specialists. As I explained in the previous slide, that in the remote areas, that is one of the key challenge. So using these short structured questions that help service providers match symptoms to likely mental health conditions, offer clear guidance on what basic treatment to start at the clinic level, and flags warning signs that require referral to the higher level of care. So on the right side, you can see two components of this slide. In the first slide, it shows the structures of the standard questions. And the second component, it shows the management protocols. Next slide, please. So what this look like in the practice on the ground? I will just give an example. During a routine home visit, the community health and nutrition volunteer or community health worker found a patient withdrawn and struggling to care for her 3-month-old child. Sensing possible depression, the CHNV brought this information to the mobile clinic team during the monthly visit to the village. Using the mental health gap protocols, the doctor asked short, structured questions that confirmed the diagnosis of postpartum depression. The doctor provided initial counseling, support, and guidance for improving sleep. Because the patient reported thoughts of self-harm, the doctor issued an emergency referral voucher and arranged her referral to the nearest mental health specialist for ongoing care. Next slide, please. Field experience and impact. In crisis-affected area, mobile teams conducted over 100,000 consultation annually, with 15 to 20% involving mental health and psychosocial support. Service delivery contributes to reduce morbidity, improved continuity of care, and community trust. Evidence shows improved treatment adherence and family coping mechanism when mental health support is available. Next slide, please. Top mental health conditions seen by the mobile clinics. So this highlights the acute stress and anxiety, depression, trauma, post-trauma stress disorders, insomnia and somatic symptoms, severe mental disorders, substance misuse. So for acute stress and anxiety, overwhelming worry, excessive vigilance, and hyperarousal. Depression, hopelessness, affective flattening, suicidal ideation, trauma and post-traumatic stress disorder, intrusive memories and nightmares, avoidance, insomnia and somatic symptoms that include the chronic pain, headaches, sleep disturbance, severe mental disorders such as psychosis, bipolar disorder, acute psychotic episodes, and for substance misuse, problem with alcohol, drugs, or coping substances. Next slide, please. While implementing the services and delivering the services, the mobile clinic teams face several challenges, and I will highlight key challenges that include the access restrictions and security constraints, hinder mobility and supervision, staff well-being, high burnout among mobile clinic teams, stigma and cultural beliefs affect the service uptake, especially at the community level, referral gaps for the severe cases. In remote areas, as I earlier mentioned, that there is a lack of human resource availability with the qualified mental health specialists. And there are also challenges to identify the clinics or the hospitals who have proper mental health case management support available in some areas. So that is one of the gaps which I wanted to highlight about the referrals. Next slide, please. Innovation and integration. So considering the context, The team used digital tools for the reporting and monitoring, integration of health, nutrition, and MHPSS in one platform, collaboration with other stakeholders to strengthen the referrals, community elders and community volunteers and community health workers engagement to deal with stigma, flexible operational planning on access and conflict mapping. The last slide, please. As a way forward, expansion of integration of MHPSS within all mobile clinic operation, invest in capacity building of health workers and community health and volunteers on MHGAP models, strengthen referral pathway and follow-up mechanism for severe cases, develop staff care framework and supervision systems, advocate for multi-sectoral approaches linking health protection and education. Thank you very much.
Thank you so much, both Dr. Nisar and Monette. For the next portion of our webinar, we're going to have a panel discussion led by Wian. Wian is a mental health specialist at ADRA International, and she's going to guide this next part of the conversation. Still with Dr. Nisar and Monette. Two reminders, if you have any questions for either of our presenters or both of our presenters, please write them down in the chat and we'll be sure to get to any questions that you might have soon after the panel discussion. Another reminder, if you would like to follow this discussion in another language, please be sure to click CC in the bottom panel of your Zoom, or the three dots. You'll find the caption option, and you'll be able to select the language of your choice, which will give you subtitles, just like you're watching your favorite movies, but instead it will be your favorite mental health specialist, and you'll be able to read what they're saying in the language of your choice. If you have any questions, please put them in the chat. With that, Wian, over to you and our lovely panel.
Thank you very much, Tino, and thank you both for your presentations. So to everyone, we've heard two different approaches that still share one aim, and that is making mental health support accessible in places where it's rarely available. So now let's shift into the panel discussion by looking at how these approaches took shape in practice. And our goal here is to draw out the decisions, the strategies that can hopefully guide other teams in the ADRA network to explore or strengthen mental health integration. So let's start with you, Dr. Nisar. Your team had to integrate mental health into what was an already demanding service model. How did you decide where to begin, and what were the most important first steps?
Thank you, Vianney, for the question. In terms of integrating mental health into the existing service model, initially in our health project, mental health was not as systematically included in the primary health response, largely due to the urgent focus on the life-saving services. But later on, when the routine services were provided, we observed that there is a high caseload of beneficiaries suffering with the mental health disorders. So considering that, and also considering the protracted phase of conflict context in Myanmar, we decided first to do the assessment and see what are the needs in the target areas. So the assessment was conducted both with the healthcare staff and also with within the affected communities to understand the prevalence and the types of psychosocial distress. Later on, we had stakeholder engagement and coordination with the local health authorities, including local partners, community leaders, and to ensure alignment with the existing services to avoid any duplication. So we had a coordination with the cluster. Then the third step was one of the key step, that is the capacity building of health staff, recognizing that primary healthcare providers were already overstretched. We prioritized training on the basic mental health and psychosocial principles, psychological first aid, and referral pathways using the WHO guidelines. Then we also put in place the monitoring practices that can regularly get feedback from the healthcare providers and also from the beneficiaries on the services which will be provided by the mobile clinics, specifically on mental health and psychosocial support. Yes, back to you. I hope I answered your question.
Yes, thank you very much, Dr. Nisar. Now, Monette, I'd like to shift to the funding side. You've seen what strengthens a mental health proposal and what donors respond to. So from your experience, what makes a proposal more competitive, and what core elements should a team have in place before they start seeking funding for mental health activities?
Thank you, Vian. It's a challenge to get money for mental health, that we know that. It is stigma. It's not popular, even here. I mean, nowhere in the world where it doesn't have any challenges. Now, when I try to get money for mental health, I always focus on that mental health is an amplifier, so that everything else in your program will multiply and be even better if we also focus on mental health. Because when people feel okay, they have much more potential of doing a good job. And also for the communities, if they manage to do even better, their prosperity will grow, and your result from your money will multiply. That's what I focus on when I try to get money from donors. Now, what needs to be in place? Well, first of all, I mean, I started in Niger, and to have somebody that is passionate about mental health, to have a mental health champion locally. I was lucky to have our staff there who is a psychologist, and then to find other mental health champions there. Now, what we did to begin with was that we taught the same curriculum, which basically what I showed you earlier, to teachers, head teachers, community workers, health professionals. We just added mental health gap to the health professionals, so they would have even more of resources, which is a great tool for those that are not in the psychological field, but also to parents and even children in the schools, so that all of the community, the whole community, got sort of the same knowledge of how mental health works, how feelings work basically, and why that is important. So that gets back to one of the questions here about stigma. How do you address cultural stigma for mental health? And my answer to that is, it's difficult, but by focusing on that we all have feelings, and that feelings is the ones that give us, energy when they're good, usually, but is also what is very difficult when there's hard feelings, to find that common ground where everybody can agree that, because feelings are not as dangerous to talk about as mental health problems. So that's usually where I keep the focus, so to speak. Hope that helped.
Great. Thank you, Monette, and thank you, Dr. Nisar. We're getting a lot of questions in the chat, which is great. Thank you so much, everyone, for your interest in this topic. So I'm going to start going through them. Monette, you already answered the first question regarding stigma. So let's go to the second one. And the question is for Dr. Nisar. Are all cases referred, or is ongoing counseling, which is more than 1 or 2 sessions, part of the mobile clinic? And do the referral centers provide antidepressants, mood stabilizers, and other drugs?
Okay, it's not all cases are being referred to the hospital or the health center. Only the critical cases which are not being in the capacity of the mobile clinic staff to manage. So those cases are being referred to the health center. In terms of providing the counseling, the mobile clinic staff is visiting the same community on monthly basis, and then the community health and nutrition volunteers, they can do follow-up with the critical cases to provide the counseling. So the counseling is happening at the both level, at the community and at the mobile clinic site on the monthly basis. For the cases which are being referred to the hospitals, yes, they do provide the antidepressants, but it's subject to the availability of the drugs. Sometimes, as the public health facilities are struggling with the availability of the pharmaceuticals and medical consumables. So if they are not stuck out, they are providing the antidepressants.
Thank you, Dr. Nisar. Our next two questions are somewhat related to each other, and they have to do with religion. So, have you encountered instances where religious or faith-related interpretations discourage people from seeking mental health care? And what role does religion play in the context of management and referral of mental health issues within the community level in the field? So, this could be answered by either one of you. How have you seen faith impact mental health service provision and access?
I can start answering. Yes, religion is a contributor, usually negatively, because when people are really sick from mental issues, it can be seen up as the devil has taken place in you, it's a curse put on you, and so forth. Now, I think the knowledge about how mental health works, and that's why I also in the trainings of the mental health champions and the other members of the community, I just talked about teachers and head teachers and everybody. We have a short session on the different mental health illnesses, and sometimes also why trauma can look like schizophrenia, why you get voices and hears things and so forth, just slightly, so that people understand that it's not a curse. But again, I usually focus on feelings and the common ground, that we react like this when we're afraid, we can react like this when we are have experienced things and so forth, to help people see a little bit themselves in this. Yes, I think that was my answer. Thank you.
Thanks, Manette. Donna and Dr. Nisar, if you also wanted to respond to that.
Yes, I will have some different experience. I will try to share some example from Liberia during the Ebola response. So I can say that the religion played a positive role. The religious leader, considering the context during that time with the huge Ebola outbreak, the religious leader from Muslim community and from the Christian community, they played a very positive role. First, it depends that how you approach the religious leader so that they can convince the community members. So we had several meetings with the religious leader to explain the agenda and what are the activities which will be done at the community level, and why it's important for the sick people with Ebola to get the treatment at the Ebola treatment units. So when we managed to give proper explanation to the religious leader, so they played very positive role at the community level to convince the community members to get the treatment in timely manners in the treatment centers. And also acceptance of the Ebola survivors. So there was a high level of stigma among the Ebola survivors because they were rejected by the communities. So that's where the religious leader, they played their role to bring back those survivors into the communities.
Okay, thank you,
Back
Mona
to
and
you,
Dr.
Anna.
Nisar, for those two perspectives on how faith can both positively and negatively impact help seeking for mental health. The next two questions are related to the cases that you see in the field. Do you find cases of domestic violence and how do you deal with it? And as also, how common is postpartum depression in your experience in the field? So could you speak about like those two cases, postpartum depression and domestic violence?
Let me start with the domestic violence. So it has not been officially reported through the mobile clinics because there is also a level of stigma at the community level considering the context and the culture. So we did not see any case recently. And in terms of postpartum, it's quite common. That's why I put it in the example. So it could be related to the protracted phase of the conflict, where people are having continuous stress and also social economical barriers to manage their lifestyle. So it's quite common, have been seen in the mobile clinic teams.
Thank you, Dr.
Back to
Nisar. This next question now is for you. What can we do as humanitarians or mental health champions to avoid making the situation worse for those that are suffering? It's a loaded question.
It's easy to be afraid that things will be worse because we see how bad people or how much people are suffering. Now, I think by not doing anything, you basically make things worse. But getting to the chase, I think, like I said, listening is the most important. And for your peers and also for those you help, then again, by asking too many questions, when you feel that you become curious of the story rather than a listener, that's where you should be cautioned. Because when you start to be curious and asking too many details because you're curious and not because you think it'll help the person, that's when you can re-trigger the trauma, so to speak. So this is the key thing to have in the back of your head when you do debriefs with colleagues or something, or you help others, to stop where you're starting to get curious. But to be an active listener, to be interested in the story, that is very important.
Thanks, Monette.
Yep.
The next question is, and I think I can also answer this next one. The question is, can mental health be classified as a disability? And if so, can it be included in the vulnerability criteria for programs such as food distributions? Secondly, due to drug and substance abuse, we have a high prevalence of mental health cases. How do we address this in beneficiary selection? So that's a good question. On the first question, yes, mental health conditions can be considered disabilities if they limit someone's ability to function in daily life. So this is consistent with the WHO guidelines and the UN disability framework. So for example, if a person living with severe depression cannot get out of bed or cannot manage daily tasks or safely care for their dependents, this would fall under a vulnerability category. And this means that they can be included as part of your criteria as long as it is defined in terms of functional impact rather than a specific diagnosis. And this applies to those with substance use. What matters really is the level of impairment. For example, someone who has substance abuse disorders can have poor nutrition, they might be unable to work, or they may not be able to care for their children who need additional support. While another person using substances could still function well, right? So instead of creating a separate criteria for or category for drug use or mental health conditions in your vulnerability criteria, you can just integrate it into your existing criteria, such as maybe those who are unable to meet basic needs, those who are unable to care for their children, or those with limited social support. By doing so, we're avoiding stigma because we don't want people to think that, oh, people who are addicted to drugs, they get support. That's not the message. They get money or they get additional food. That's not necessarily the message we're sending. We also don't want them to be stigmatized and pointed out in their communities. So instead, we can just define that category in terms of functional impairment rather than, oh, they have a mental health disability or, oh, they have a substance related challenge. So thank you. That was a good question. We are managing to make it through the questions. We are making it through a lot. So this last question before we close. Do donors respond positively to programs that include advocacy and climate initiatives in areas such as food security or WASH, particularly in Africa when integrated into mental health programs?
I think the only way to do good mental health programs or to get funding for it is to integrate it into other programs. We also do food security in the education programs that ADRA Norway has. But yes, with the limited funding there is, I mean, it's stated that it's only 1% of health funding that goes to mental health initiatives in the world. And probably even less now with the funding restrictions all over the place. So yes, again, I think it's easier to get funding doing it through other programs. But if you're curious, I also have, I noticed that there's a couple of our mental health champions on the chat. Maybe they want to raise their hand or unmute themselves and tell us a little bit about the most challenges and the most rewarding it's been to be a mental health champion.
Sure, Monette, maybe you can point out their names and I'll add them to the spotlight.
It's I saw Shamsa and Latifa on the chat. I know, yeah. I'm putting them a little bit on the spot, but since we have time.
Let's see, Latifa
and Shamsa.
And Shamsa. If you wanted to share a little bit about your experience, maybe in 3 to 5 sentences, what has your experience been in being
or
a
in the
mental
chat
health
if you want
yeah,
to.
or in the chat and being a mental
While
health
they're thinking,
champion.
I can add something because we had there was a question here I saw somewhere about the structures, and we just recently saw a structure in one of our countries where we have a student council that without our awareness before afterwards, the student council had prevented a child marriage. They saw because we have attendance tracking in our schools, where the names are listed every day. The students are more aware of other students being not present. And then, that's another thing, mental health thing. Your name matters. So put that on your mind. But at least they noticed that they heard about a girl that's going to become married. They didn't like it, so the student council themselves intervened and prevented that marriage from happening, and the girl is still in school. So when the structures are in place, when the support are in place, we also, good things happen not by themselves, but without us as donor offices intervening.
Excellent. That's a positive note to end this panel and Q&A on. Thank you very much for your responses to these questions. I see a question in the chat right now, Monette or Dr. Nisar, if you could respond to that. Maybe, yeah, just really quickly now. For how long should MHPSS activities be integrated within a project?
For the whole project period. It's sort of like the oil in the machinery. It's the amplifier of everything you do if you have some focus on it. And the more focus you have on it, the more you realize that even the calling of the names in attendance tracking is also a mental health prevention tool. So it's not only the distinguished mental health activities that helps, the resilience and the prevention of further damage and also, so forth. Thank you. Yeah, Shamsa Noor, a few last words. She's raising her hand.
Hi, Shamsa. Go ahead.
Hey, thank you. I'm Shamsa Noor from ADRA Somalia. Thank you so much for this. It has been very interesting. I'll just talk about like the most challenging thing that we faced as being the mental health champion in Somalia. It being a region that has stigma towards mental health, it has been very difficult because there's that misunderstanding and it being related to the religion, and yet it's more of culture and all that. We've tried creating more awareness on it, and I think the most beautiful part of it is we see the impact that having these conversations have had. Previously, I was telling Monet on how we were having a video for the International Children's Day, and one of the girls talked about how wanting to become a mental health practitioner in the future. This shows that previously the children will talk about becoming a teacher, a nurse, pilot, or something else, but coming from a country that has a lot of stigma towards mental health, and one of the children talks about becoming a mental health practitioner, shows that there's that positive approach towards mental health. So it's a very beautiful field to be in, and being one of the champions, it has been very empowering. Thank you.
Thank you so much, Shamsa. It's a privilege to be able to have you here and share your experiences as someone who's out there in the field doing all this work. Thank you very much for sharing.
Hi.
Yes? Mhm.
Yes, Latifa, she's
Latifa.
also a mental health champion.
Hello. How are you?
Good. Yes,
Thank
go
So
ahead.
being a champion is incredibly passionate for me particularly, but it also comes with its share of challenge. There are many challenge, pressure, stress. Sometimes when we go with people, they are reticent. So there are many challenges, but with Monet, we have always solutions. So she take care of this. So we are going to thank her and keep it going. Thank you.
Thank you very much. And yeah, thank you that just speaks to like also the importance of the support that we get, if you're in a support office, like you also have a big role in the field. Thank you very much to our panelists, our speakers, and everybody who put in their questions. I'll pass this on to Tina for the closing remarks.
Thank you so much to our presenters and those who jumped in to share some words after the Q&A. And thank you everybody for joining this webinar. This was a very informative discussion for myself. I hope it was for you as well. Just before we leave, we have a QR code on the screen. If you can, please take a moment to scan that QR code and complete our short satisfaction survey. It really helps us to strengthen future TLL sessions that we hold. We are also going to continue this conversation. So soon after this webinar closes, in about a minute, our presenters have kindly made themselves available to stay on after the webinar. So once we officially close, we're going to end the recording, but we're going to keep the line open. If you still have questions, if something sparked your curiosity and you'd want to engage further with our presenters, please remain. And both Monette and Dr. Nissar and Wiyan are going to be available to discuss it further with you. You're welcome to stay. Again, thank you so much for being part of today's session, and I look forward to hearing comments from you through the satisfaction survey. Have a great morning, afternoon, or evening.